Good evening, everyone, and thank you for attending the Cancer Council Victoria and the McCabe Centre for Law and Cancer's webinar on advanced care planning. My name is Sondra Davrin. I'm the facilitator for the webinar this evening. I'm a Senior Legal Policy Advisor at the McCabe Centre for Law and Cancer. So before we start, I would like to acknowledge the traditional owners of the land we're meeting on today, those of the Boonwurrung people of the Kulin Nation, but also recognising that this webinar is being broadcast across Australia and even, or across Victoria and even Australia, also to the traditional owners of the land elsewhere. And I also pay my respects to their elders, past and present, and all Aboriginal people here today. So today's webinar is around an hour in length. We're going to be followed by half an hour of question time after the 1 hour substantive webinar, and that's an optional section for registrants to stay online and to have a Q&A with our panellists. We're firstly going to hear from Dr. Deborah Lawson, who's a legal policy advisor at the McCabe Centre for Law and Cancer. She's going to go through some of the concepts and key elements of advanced care planning with an emphasis on clarifying and demystifying some of the legal terms and requirements of advanced care planning. We're then going to have a short panel discussion where Deborah will be joined by Dr. Jenny Wheel, a physician in palliative medicine at St Vincent's Hospital, Melbourne, and Clem Bayard, a clinical nurse specialist who works on the 13 11 20 Cancer Information and Support Line at Cancer Council Victoria. And they'll give some of their perspectives and reflections on advanced care planning and also answer some of the questions that were posed by some of you during the registration process. And I'll introduce Jenny and Clem later in the session. So again, just to remind you, from around 7 o'clock to 7:30, we're going to be online to answer any specific questions about advanced care planning and also to provide more information about the services offered by Cancer Council Victoria, and you're welcome to stay and chat with our panellists or one of our cancer nurses. There is a question and answer function with this webinar. We have disabled this at the moment, but it will be available up in the top right-hand corner of the webinar platform later in the session. As I say, it will be turned off for the duration of the presentation. We do find that many questions are answered in the course of the webinar, but if there's anything that we haven't addressed, we look forward to hearing from you at the end. So just a note about the content of our webinar today. So we understand that the topic we're discussing today can raise some very sensitive issues that may be upsetting for some people. We'd like to take the opportunity to remind participants that although we're talking about matters that can be quite personal, this is a public forum, and we encourage people to consider this when commenting or asking questions. And furthermore, if you do find that the discussion is causing any distress, you may like to contact Cancer Council 13 11 20, which is the gateway to all information and support services provided by Cancer Council Victoria. This phone line is staffed from Monday to Friday, 9 till 5. It's staffed by practicing cancer nurses who work a few days in a clinical setting and then a few days at Cancer Council Victoria. They are on hand between the hours of 9 and 5 to provide information and support, whether you have cancer, are wanting to reduce your risk of developing cancer, or are a family member, friend or colleague of someone with cancer. And the service is free and all conversations are confidential. So before I hand on to Deborah Lawson, I'd just like to say a couple of words. Sorry, I'm just waiting for the slides to catch up with my conversation. But I will just say a little bit about the McCabe Centre for Law and Cancer and Cancer Council Victoria's work in this area. The McCabe Centre for Law and Cancer is a joint initiative of Cancer Council Victoria and the Union for International Cancer Control. It is a specialist law and cancer centre that is based at Cancer Council Victoria, and its aim is to contribute to the effective use of the law for cancer control. Our work spans domestic and international law. We have a key focus on tobacco control as well as the regulation of other cancer risk factors. We have a focus on the intersection of law and cancer treatment and support, including access to treatment and care, discrimination, regulation of alternative therapies and end-of-life decision-making, access to medicines, improving access to, ensuring that drug control laws do not impede access to morphine for the relief of cancer pain, and also the role of law in combating the rising global burden of cancer and other non-communicable diseases. As part of this work, the McCabe Centre is the proud recipient of a grant from the Legal Services Board of Victoria for a project entitled Making the Law Work Better for People Affected by Cancer. And a key part of our work, and the reason and the rationale for our webinar today, is improving the understanding and the use of law in the context of decision-making at the end of life. And more information about our work can be found on the McCabe Centre website. And finally, just to point out, although we are giving information that is of a legal nature, this presentation and the discussion today is not legal advice and it shouldn't be relied on as such. If you do have specific questions about your personal circumstances, then it's important to seek independent legal advice, and we can provide that information and support through the 13 11 20 line. And I'd also like to emphasise that the legal information presented in this webinar is Victoria specific. As Deborah will explain later in her presentation, the law does vary from state to state in Australia, so if you are listening or participating from another state, please bear this in mind and seek further information from a cancer counsel in your state and territory. So it now gives me great pleasure to introduce Dr. Deborah Lawson, Legal Policy Advisor at the McCabe Centre for Law and Cancer. Deborah is a legal policy advisor who's been working at the McCabe Centre in our law, cancer treatment and supportive care work since early 2013. Deborah trained and practiced as a lawyer in New Zealand before undertaking a PhD in law, which examined child protection laws. She previously worked as a research fellow at Otago University, exploring regulatory options for genetic testing of children and young people. And since moving to Melbourne in 2007, she's worked on youth disability advocacy and multicultural youth policy, in addition to teaching research and policy courses in the youth work programs at Australian Catholic University and Victoria University. Welcome, Deborah.
Hi everyone, thank you for that introduction, Sandra. I thought I'd begin by talking about what advanced care planning actually is. It's the process of discussing and planning your future health and personal care to guide medical decisions made about you if you become unable to communicate or to make your own decisions. It's about sitting down with your loved ones and doctor or medical team and talking about what might be ahead for you and your preferences about the kinds of treatments and conditions you would or would not want in the future. And the law has a role in advanced care planning in two key ways: through enabling the appointment of substitute decision makers or agents who can make decisions for you if you become unable to communicate or to make your own decisions, and through advanced care directives, which are documents that record your views, wishes, or decisions about medical care that you would or wouldn't want in the future if you become unable to communicate or to make your own decisions. It's important to remember that these processes for decision-making in respect of your care and treatment only kick in if you become unable to communicate or to make your own decisions. For example, if you lose consciousness. Otherwise, you'll be the one who continues to make your own medical decisions. So why is advanced care planning important? The advanced care planning process provides a useful opportunity to open up the discussion about your future care and treatment with your loved ones and with your medical team. Talking about the end of life in particular is something that people, including doctors, often avoid and that people may find difficult to raise with their families. Loved ones may not know what you want in terms of medical procedures or treatments, or they may know what you want but not accept it, or may end up substituting their own wishes or values and making decisions for you. Additionally, different family members can have different views and wishes about your treatment, which could come into conflict at an already difficult time. I thought I'd introduce William to help explain things a bit better. William is a 65-year-old man with bowel cancer. His wife Sharon passed away from secondary breast cancer 7 years ago. William has 3 adult children. You can see pictures of them to the right there. Robert is a 42-year-old unemployed man who lives in Melbourne. Laura is a 40-year-old accountant who lives in Perth with her husband and 2 small children, and Rebecca is a 36-year-old lawyer who lives alone in Melbourne. There was a great deal of family disagreement and conflict over what treatments should and shouldn't be provided in Sharon's final days after she had lost consciousness. William is very independent and he wants to make arrangements for decision-making about his medical care in advance so that his own wishes inform his treatment if he loses consciousness or is otherwise unable to make his own decisions. He has particularly strong views about not wanting to spend his final days unconscious, hooked up to machines in a hospital. So what are William's options? There are a few different advanced care planning options to consider, including appointing an agent, recording your wishes, doing both, or doing neither. If you do choose to do advanced care planning, you can appoint an agent and record your own wishes in writing, or you can do one or the other. For some people, simply appointing an agent who they completely trust to make the right decisions for them may be all that they wish to do. Other people might choose to record their wishes in writing without appointing an agent. For example, if they have particularly strong wishes about their future healthcare or treatment options, if there's no one that they would wish to appoint, or if there are different views about medical treatment within their family. Again, it's up to you and what's going to be best for you in your circumstances. One of the benefits of doing both is that your agent will have a good idea of your wishes if they have the written document to refer to also. This might be particularly useful if the agent is in a stressful or emergency situation where a difficult decision needs to be made quickly. Or it can be useful if there's something that you feel particularly strongly about that you want to ensure your medical team knows about. Regardless of what you decide to do, if you wish to have some input into your future treatment, it's important to talk to your loved ones and doctors about your values, beliefs and healthcare preferences, and to tell them about what's important to you. It's also useful to talk to your doctors to find out more about what might be ahead for you. You can participate in advanced care planning as much or as little as you want. There are no right or wrong choices. It's about knowing your options and considering what's right for you. The aim of this webinar is to give you information about how to go about each of these processes and the legal rights and responsibilities that they give you and any agent that you might appoint. So when should you consider advanced care planning? Whenever feels right for you. Advanced care planning can have value for people at any stage of life, particularly appointing an agent to make decisions for you. If any of us were suddenly hit by a bus, for example, then we might be reassured to know that we've appointed someone who understands us and our values to make important medical decisions for us. Recording your wishes in writing might be particularly useful for people with disease, particularly chronic or advanced disease, or people undergoing risky medical procedures. If you are going to do it, advanced care planning must be done before you lose the ability to communicate or to make your own decisions. You need legal capacity to undertake these processes. And capacity is the ability to understand, to retain, to use or weigh and to communicate the information which is relevant to the decision that you're making. So, for example, with appointing an agent, the relevant information would be what the agent's powers were, that the power kicks in if you lose the ability to make your own decisions, that you can change your mind while you have capacity, and that once you lose capacity, you won't have a say in how the agent uses the powers. And you need to be at least 18 years of age to undertake many of the advanced care planning processes I'm talking about tonight. So there are a number of different agents that you can appoint to deal with various aspects of your life in case you lose the ability to make your own decisions. In Victoria, there are 3 different types of enduring powers of attorney which provide authority over different things. There's an enduring power of attorney medical treatment, enduring power of guardianship, which provides powers in relation to personal and lifestyle decisions, such as where you will live, and financial power of attorney, which provides powers in relation to your financial and legal affairs. The type of enduring power of attorney most relevant to advanced care planning is the enduring power of attorney medical treatment. An agent appointed by an enduring power of attorney medical treatment has the following rights and responsibilities in respect of you and your medical care. They have the power to consent to medical treatment for you. Their power to refuse medical treatment for you is limited to situations where the treatment will cause you unreasonable distress or they reasonably believe that you wouldn't want the treatment. Your agent doesn't have the authority to refuse palliative care for you, and that's defining palliative care as the relief of pain, suffering and discomfort and reasonable provision of food and water. When making decisions for you, your agent has a responsibility to act in your best interest and to represent your healthcare preferences with the aim of, wherever possible, making the same decision that you would have made. And your agent's decisions will have the same legal force as if you had made them yourself. So you can see that it's very important to talk in detail with the person that you appoint as your agent about your preferences. So to help your agent understand what you would want, it's useful to talk to them about your medical condition and what may happen in the future, your values and beliefs and things in your everyday life that are important to you, future situations related to your health that you would find unacceptable or too distressing, including certain procedures or outcomes of procedures or treatments, any particular treatments that you would or wouldn't want, and other people that you might like involved in your medical decisions. Given all of the information you might want to discuss with the agent, you might be thinking about who you should appoint. Your agent doesn't have to be your favourite family member. Perhaps two of the most important things to consider are, is the person going to be available, and would the person understand and agree to act in accordance with your wishes and values? It's also obviously important to consider whether you trust them. It might also be useful to think about who's good in a crisis and who's good at communicating with doctors about your condition. But it's really up to you to decide what's most important to you and your agent. The Office of a Public Advocate has a great online resource that you can, I've got the hyperlink there that you can click on later when we send the slides around. And this resource is really useful for getting you thinking more about who to appoint to make decisions for you. It allows you to select a character and go through the decision-making process with them to give you an idea of things that you might want to consider. You can only appoint one agent, but you can appoint an alternative decision maker so that if your agent can't carry out the role at the time that you need them, there's someone else to step in. But an alternate agent can only act if your agent loses capacity, dies, or they're absent for a period of time. So let's check in on William. He's decided to appoint an agent. He has advanced cancer and is concerned about having treatment intended only to prolong his life rather than to promote his quality of life outside the hospital environment. He carefully considers which of his children understands and accepts his views about life-prolonging hospital treatment. He also considers who he trusts to be able to communicate these wishes effectively on his behalf, not only to his doctors but to the other family members. His son Robert is not so good in a crisis, and he insisted everything be done to prolong his mother's life, even although the rest of the family wanted to let her go peacefully. William thinks that Laura will be the best person to choose. However, because she lives in Perth with her two small children and there's a chance she may not be available, he decides to appoint Rebecca as the alternate agent too. Now that William has decided to appoint Laura as his agent, he'll need to know how to go about making the appointment. The good news is it's easy and you don't need a lawyer. Forms for appointing an agent can be downloaded from the Office of the Public Advocate's website, and they're also available from any newsagents. Fill it out and have it witnessed by two people, one of whom must be a person who can sign statutory declarations. So, for example, a doctor, a dentist, pharmacist, lawyer, a GP, a police officer, or a religious minister. It's important to know that your agent cannot be one of the witnesses on the form. So let's take a look at what the form looks like. It's a very simple one-page form. So hopefully that's come up on your screen. So you can see that you just fill in the date, your own details, and then the details of the person that you're appointing, or the details of the two people that you're appointing as your agent and your alternate agent, and then there's room at the bottom there for your witnesses to sign. So it's a pretty simple process. So what do you do next after you've appointed your agent? You don't have to register or send that form anywhere, but it's a good idea to keep the original in a safe place and to keep certified copies for everyday use. It's really important that you tell people that you've appointed an agent, particularly the agent, of course, loved ones that you haven't appointed, and your medical team. So give copies to your GP, to your oncologist, to the agent, your solicitor, and family members or friends who might be involved in your medical care. Ask your doctor or the hospital to place a copy of the form on your medical record as well. And you might want to stick a copy on the fridge. If something happens to you at home, the paramedics will look there. You might be wondering whether you can change your mind about who you'd like to be your agent. You can cancel the appointment at any time as long as you still have capacity. Do this by telling the agent and destroying the original document and any copies. The Office of a Public Advocate recommends that you also complete a revocation of enduring power of attorney form and give a copy to your agent. I've included a hyperlink again on the slide that you can click on later to access that form. If you do appoint a new agent, then any earlier appointment is automatically cancelled, but you should let the original agent and your medical team know to avoid problems down the track. So in summary, if you decide to appoint an agent, it's important to appoint someone that you trust and to talk in detail with them and your medical team about your values and preferences. Your agent has the right to consent to medical treatment on your behalf and to refuse treatment where it would cause you unreasonable distress or they have good reason to think that you wouldn't want the treatment. Your agent can't refuse palliative care for you. Make sure that you tell your agent and other loved ones that you've appointed the agent and give key people copies of the form and have one placed on your medical record. And you can change your mind if you decide you'd rather appoint someone else. Now we're going to talk about the legal options for recording your wishes, whether or not you choose to also appoint an agent. The only option for recording your wishes about future medical care that has been legislated for by the Victorian Parliament is the Refusal of Treatment Certificate. You may have also heard of advanced care directives or advanced care plans as a way of recording your wishes. These are another option, but their status in law is slightly less clear, which we'll discuss as a panel later if we get time. So you or your agent can refuse future medical treatment for a current medical condition by signing a Refusal of Treatment Certificate. It's important to be aware that Refusal of Treatment Certificates can only be made about a condition that you already have, so they are only an option if you currently have disease. For example, you can't sign a general Refusal of Treatment Certificate saying that if you ever have a stroke or a heart attack that you would not want to be resuscitated. You can't use a Refusal of Treatment Certificate to refuse palliative care. Medical practitioners can't treat or continue to treat you if they know that there is a valid Refusal of Treatment Certificate in force. These certificates are usually available in hospitals and nursing homes, so ask your doctor to help you find one. You can also get one from the Office of the Public Advocate, and there's a link there that you'll be able to download one from later. When completing the form, you need to specify the type of treatment you wish to refuse, which could be all medical treatment, except for palliative care, or specific treatments, for example, artificial respiration. To sign, you must have been given sufficient information about your condition, understand the information and what you're doing by signing the certificate, and be making the decision voluntarily. A doctor and one other person must witness the signing and be satisfied that these requirements have been met. So we'll take a look at that form as well, just to show you. So you can see here that this is the page that your doctor signed, so they certify that they're satisfied that you, in relation to a current condition that you have, are refusing either medical treatment generally, or there's space to record specific treatments that you want to refuse. And then the doctor signs and dates that form, and the other witness does as well. And if you scroll down, Sandra, just at the top of that second page, that's where you sign also. So again, it's a simple form to complete. Your agent can also refuse medical treatment in this way on your behalf. The same conditions need to be met as above, but in addition, the agent must be convinced that either the medical treatment would cause you unreasonable distress, or they reasonably believe that you would, after serious consideration, not want to have the treatment. Most of these certificates are signed in hospitals or other health services, but you can sign them at home. But you need to be at least 18 and have capacity to sign those forms. A valid refusal of treatment certificate will trump your agent's decisions about your medical care, so it's very important to tell people that you've completed one, particularly any agent that you've appointed, other loved ones, and the medical team involved in your treatment. A copy of the certificate must be provided to VCAT within 7 days of signing, but this will be done by the doctor who signed or someone else at the hospital or health service. Ask them to ensure that a copy is also placed on your medical record. Keep a copy for yourself and give copies to your GP, oncologist, agent, and family members or friends who might be involved in your medical care. And again, you might also consider sticking one on the fridge. And you can change your mind after completing a refusal of treatment certificate as long as you still have capacity to understand what you're doing. Certificates can be easily cancelled at any time by signing a notice of cancellation form, and there's a link on this slide to where you can find one. Now, if you don't have a current condition for which you can complete a refusal of treatment certificate, or you'd like to have more of a conversation and provide more written information about your wishes, values and preferences in respect of a range of different medical and care options, then you might want to consider making an advanced care directive. These are called different things in different states, territories and countries. For example, advanced directives, advanced care plans, advanced healthcare directives or living wills. We're going to use the term advanced care directive. An advanced care directive can be as simple or as detailed as you like. If you have religious beliefs that may affect your healthcare decisions, you can record these in your advanced care directive. Advanced care directives provide more scope to really explore situations and outcomes that would be acceptable or unacceptable to you, and can provide much more guidance to your agent, loved ones or doctors about how a decision can be made about your treatment or no treatment that fits with your values. The form of an advanced care directive is not as strict as the refusal of treatment certificate that we just had a look at. An advanced care directive can even just be in the form of a letter. Open and ongoing conversations with your agent, other loved ones and your doctors can contribute to the form and content of an advanced care directive. Different health services offer different templates for advanced care directives based on the same general idea. Cancer Council Victoria doesn't currently recommend any particular form or template, but I've got a useful example here from St Vincent's that Jenny has kindly directed us to, so we'll pull that up and have a look. So you can see on the first page here that it highlights the importance of advanced care planning. And then there's a section for giving details about yourself and who you want to be involved in your treatment, including whether you've formally appointed those people as your agent. On the next page, there's room for information about your condition and its impact on your life, and any concerns that you have about your condition and any other concerns you have generally. And then there's a couple of spaces for talking about what it means to you to live well, including things that are important to you, so perhaps your religious beliefs or other spiritual or cultural beliefs that might guide treatment or decisions made about you. And then on the third page, there are some more options for indicating your wishes about specific treatments or outcomes that you would or wouldn't want. And then the last page is where everyone signs. So if you want your written wishes to be respected if you lose capacity, then again, it's really important to tell people that you've completed an advance care directive, particularly any agent that you've appointed, other loved ones, and your medical team. And again, keep a copy for yourself, give copies to your GP, oncologist, your agent, and other loved ones who might be involved in your treatment. Ask for it to be placed on your medical record, and you might also want to stick that on the fridge too, although your fridge will be getting pretty crowded, I guess, by now. Let's check in on William. After talking in detail with his family and his doctors, William decides to complete a refusal of treatment certificate to refuse resuscitation should he become unconscious as a result of cardiac arrest as his cancer advances. Although this is unlikely, William feels very strongly about this. He thinks that completing a certificate will give him extra protection if Laura is unavailable or if she feels pressured by her siblings. William also decides to complete a more detailed advance care directive so that he can make his wishes and values clear in relation to other outcomes and treatments that he wouldn't want if he should lose the ability to make his own decisions in another context. So, for example, after a car accident, for which he wouldn't have been able to make a refusal of treatment certificate. After all of this talk about forms and witnesses and making copies, it's important to say that advanced care planning is a journey, and it's not necessarily just one moment in time or filling out one form or having one conversation. It's an ongoing process as your medical condition and your values and wishes change over time. You can also participate as little or as much as you like. It's entirely your decision. Appointments and directives can definitely be updated. Just make sure that you let people know. So let agents and other loved ones and your medical team know when you've updated something. And finally, to finish, I thought it was important for you to know who decides about your medical treatment if you don't do advanced care planning. So if you're unable to consent to treatment and there are no agents appointed, a doctor can seek consent for your treatment from a person responsible. And that's the first person in the following list who is available. So your spouse or your partner, your primary carer, your nearest relative over the age of 18 years in the following order. So a child, a parent, a sibling, a grandparent, a grandchild, your uncle or aunt or a nephew or niece. Where two relatives are in the same position, for example, you've got two children, the elder will be the one responsible. But it's important to know that none of these people, unless they have been appointed as your agent by you or by VCAT, can refuse life-saving medical treatment for you if you're unconscious, even if you wouldn't want that treatment or it would cause you unreasonable distress. For example, you might not want to be resuscitated, as this can be painful and distressing. You need someone to sign a document declaring that you're not to be resuscitated. And once you've lost capacity, only a formally appointed agent can sign such a document for you. So appointing an agent is the only way in which you can have control over who will make that kind of decision for you if you can't make it for yourself. And time for one final check-in on William. If William doesn't appoint Laura to be his agent and he doesn't complete a refusal of treatment certificate, or the circumstances in which he completed it don't arise, and he hasn't completed an advanced care directive, then it would be his son Robert who would make decisions for him if he loses the ability to make his own, which, as we know, isn't actually what he wants. And in summary, I've just got a little video here that I thought summarises all of the options in a nice way, which hopefully will play. having a few technical difficulties. And the next slide just has a list of organisations and websites that you can go to for more information and assistance.
Great, thanks Deborah for a very informative and interesting presentation. So it's now my further pleasure to introduce Dr. Jenny Wheel and Clem Bayard, who are both joining us for the panel discussion part of this webinar. And as you know, when you would have registered for the webinar, we asked people to submit a specific list of questions or queries that they wanted our panel to answer. So thank you everyone who submitted a question, and I apologise if tonight we're unable to answer your question. We may be able to follow up on this in the Q&A session to follow, or happy to follow up offline later on. So Dr. Jenny Wheel is a physician in palliative medicine at St Vincent's Hospital, Melbourne, and the medical coordinator of the clinical trials group at the Centre for Palliative Care. Jenny's research interests include medical education, non-malignant palliative care, and the experience of patients with advanced illness presenting to the emergency department. Clem Bayard is a clinical nurse specialist who works on the 131120 Cancer Information and Support Line at Cancer Council Victoria. Clem has worked previously at Peter McCallum Cancer Centre and at the Centre for Palliative Care at St Vincent's Hospital in Melbourne. Clem has a background in supportive care research and has worked on projects exploring palliative care, survivorship, telehealth patient monitoring, encouraging patient self-care and improving nurse-to-patient communication. So thank you, Jenny and Clem, for joining us this evening. So to start with, just a general question, and drawing from your own experiences, why is advanced care planning important? Jenny, over to you.
Oh, thank you, Sandra, and thank you for the presentation, Deborah. I think that put it all together very clearly for us. And I guess that advanced care planning is important because it's most important to us that we do the things that you want us to do, particularly when you're very unwell. It's something that I see very often in my work, that it can be hugely stressful for families trying to make decisions for people when they haven't had some of these simple conversations. I think it's very true that it's as much or as little as you want, and so this is something that we can work together on. I think it's certainly something to talk to your doctor about, and I think we all want the things that are important to us respected and valued, particularly when we're not able to speak for ourselves. So I think it's very important.
Thanks, Jenny. And Clem, your perspectives on why advanced care planning is important?
Thanks, Sandra. Yes, I mean, I completely endorse what Jenny said in that, you know, we want to do what's best for patients. Calls about these sort of issues that are dealt with in advanced care planning come through to the 131120 number quite frequently. And so these issues are clearly of, great importance to a lot of people out there. And there's a lack of clarity, I think, about, what to do about these things to a lot of people. And that comes through in the calls we get. And not just, I suppose, calls from, patients or people suffering from cancer themselves, but also a lot of calls from family members or carers as well. So those people are in a kind of, in some ways a difficult situation in that they're intimately involved with the person's care, but fundamentally it's not their decision. So, there are a lot of kind of difficult family dynamics, and we know that those situations are difficult conversations to have. And the fact that one family member may have clarity, but there might be another family member who doesn't really want to talk about it, or, families can be divided a long way away and things like that. So these factors all make the kind of situation more difficult. When advanced care planning isn't well done, we certainly see that come through sometimes afterwards, that it can make, the situation for families later difficult, more family conflict potentially, and some cases kind of getting over what was a difficult situation even more difficult.
Thanks, Clem. And you've touched on some of the difficulties in this idea of conflict, and we know that talking about advanced care planning, it's not always the easiest conversation to have. Jenny, how do you raise the issue of advanced care planning with patients who have a cancer diagnosis?
Well, I guess that increasingly myself and other doctors are seeing this really as part of normal care for a patient. I think it's very important when we see someone either in the hospital or particularly in the outpatient clinic that we make sure that that we're touching on some of these conversations, even if it's as simple as making sure that the hospital documentation of the next of kin or the person that we should be talking to matches with what the person in front of me feels should be there. So often something that simple hasn't been done, and I mean that really all falls under this advanced care planning umbrella. Often it's just asking somebody, who would you have speak for you if you're in a situation where you weren't able to speak for yourself. Sometimes this might have come up recently, that somebody's had a presentation to the emergency department, and so that these things are fresh in their mind, but otherwise it may just come up in the course of discussion. Equally, I think as Clem has said, the more we know about what's important to you, what you value, what your views are about treatment, the more we can document these things, and it will help us. I mean, information is what we're always searching for in hospitals, and when we speak to our emergency colleagues, who are often the people faced with the situation, all they really want is information. So it can really be just quite a simple question: what would you want done if you were to come in very unwell? Sometimes we can predict what that situation might be, but many times, even if you have a significant illness, something like being hit by a bus might happen. So often we can't predict these things, so having some general ideas is actually very helpful.
Thanks, Jenny. And Clem, I guess coming from the other side, how and when should patients raise the issue of advanced care planning with their health professionals, and what sort of tips or guidance would you give somebody who was calling through to ask about that?
Sure. Well, I suppose one thing is that, ideally we'd like it to be raised as early as possible, and hopefully while the person's still well. It probably would say that it's never really too early if the person's interested in asking the question about advanced care planning, to kind of have that conversation. Certainly if someone's got significant, if they've been told that they've got a limited lifespan, they've got a lot of different kind of complicated health care issues going on, then it might be more pressing, and so we might kind of, ask a couple of gentle questions as to whether that might be something that they'd considered. So in general terms, as early as possible. But, I mean, I wouldn't necessarily rush in to, raise it with, every person who I spoke to. And certainly if someone had been recently diagnosed or things like that, that might not be the appropriate time. And so usually we'd kind of listen for some cues to try and see whether the person who we were speaking to was concerned about that, and sort of, I suppose, listening to the person who we were speaking to, and seeing what they were concerned about, and trying to get some guidance from them as to what they felt comfortable with.
Thanks, Clem. Our next question is asking whether advanced care planning is the same throughout Australia, and again reiterating that the conversation and the presentation that Deborah gave today was a Victorian-specific context. I think this is a good question for you, Deborah. Perhaps you'd like to start by answering and discussing some of the differences across Australia.
Mm-hmm. So the simple answer to that question is no. It's not the same throughout Australia. The laws relating to advanced care planning differ between the states and territories. Each state has its own guardianship legislation, which sets out when and how substitute decision makers or agents can be appointed, and each state also has different laws about when medical treatment can be refused and by whom. And one of the links that is on the earlier slide, advancedcareplanning.org.au, that website has state-specific information, so that's a good starting point for anyone who's participating tonight who isn't in Victoria. If you did end up in hospital in another state, unable to make your own decisions, it would depend on which state you're in as to the extent that the appointment of an agent that you've appointed in Victoria would be recognised. But regardless, the fact that you've made an appointment anyway would be a very clear indication to the doctors of who they should be talking to, because you've clearly expressed your wishes about who you'd like to be involved in making decisions for you. And in all jurisdictions, medical decisions made for people who can't make their own have to be made in their best interests, and respecting someone's wishes is a big part of assessing what's in their best interests. So any written records, even if it was made in another state, of your wishes would be of value to anyone making decisions about you in another state. Likewise, anything that your loved ones or family members were able to tell them about your wishes would be vital to the medical team treating them. So if you've had those discussions, again, that's going to be really helpful.
Jenny, do you have any reflections on what the different law in different states means for health professionals who might, in a mobile health workforce, what that means for people who might be travelling, and how you might respond in practice?
Certainly. So I think that that the medical decision making and the sort of the ethical framework that we use to help us arrive at often these very complex decisions is probably much the same, which is really what Deborah is saying. Doctors are often a little bit anxious about legal forms, and so I think that when we work in different jurisdictions, it really does behove us to be absolutely sure. And certainly if someone presents us with a legal form, thankfully there's lots of people that we can ask to be sure about it. The actual gist of the medical sort of sensible decision making, which is trying to use somebody's wishes, and the best way to know what somebody wants is if they've actually written it down or told someone and nominated someone that they trust. That's all going to hold. So I guess when we work in different areas and when a patient travels, we really do encourage them to take as much information with them as possible. And people going on trips is something that happens quite commonly, and that's something that requires thought and preparation, and we do send people with as much information as we can should they become unwell, but also should they become unwell, and then some of these important decisions need to be made.
And Clem, what sort of support services are offered in other states that, for people who might have dialed in or are joining us from states other than Victoria, what support services are available for them?
Sure, Sandra. Well, I know that in Queensland they've got a new program where there are 24-hour palliative care nurses on call, but that is only rolled out to Queensland at this time, and that's state government Queensland initiative. But there are other resources that are available, especially on the web, that are available across the country. So there's a service called Decision Assist, and that's got a advanced care planning phone advisory service. You can find that on the web, the link to that number on the web, and you can get some guidance, call up and get some guidance about advanced care planning from them. And there's also a website for Advanced Care Planning Australia that might be of interest to some people.
Great, thanks. So this is another question from our registrants, and I think for Deborah. How up-to-date must an advanced care directive be in order to be effective?
So the answer to that is that it will depend on the circumstances. It's probably not the answer the person wanted. But you generally don't have to write a fresh advanced care directive every year. But as I mentioned earlier, you might like to update it every now and again as your condition or any of your views change. So, for example, about what types of treatments you would or wouldn't accept. If there's a new treatment available, for example, that affects how you feel about your condition or having treatment, then you could update your directive to reflect that. But again, it's really important to make sure that you keep your agent, your family and your medical team updated about your feelings around your condition and treatment and any actual paperwork that you've updated. So one good idea might be to revisit a Refusal of Treatment Certificate or an Advanced Care Directive whenever you revisit your will. But if you don't do that very often, then it might be worth setting a reminder in a calendar to review an advanced care plan every 6 to 12 months, or you could ask your GP or other doctor to set a reminder in your medical records to check in with you about your wishes. Refusal of treatment certificates and advanced care directives can be challenged, if necessary, in VCAT if your agent or other loved ones or your medical team think that they are no longer valid, that your wishes may have changed since you completed the paperwork. So that's something to keep in mind, and another reason to keep having the conversations with your family and with your doctors. The appointment of an agent will usually stand regardless of how long ago you made the appointment. But as I said, it's a journey and an ongoing conversation. So as long as you're keeping people up to date with where you're at in terms of your thinking about your condition and possible treatments, then people should have a good idea of what you want or don't want and how up to date your wishes are. And again, all of the forms are easy to cancel and update. So just make sure that you tell people what you're doing.
So we had one final question, but in the interest of time, I'm going to, we're not going to go into this question, but there is information about this available in the report that was prepared as part of the Making the Law Work Better for People Affected by Cancer. That's really because the answer to this question is not a short answer. So we'll provide a copy, or we'll provide a link to this report which discusses some of the complexities around the legal recognition of advanced care directives in Victoria. For people who want more information, we'll provide that information. Which is to say that now brings us to the end of this substantive part of the webinar. But please don't forget that the panel are staying online to chat and to answer any further questions. And we're also going to be joined by two of our fantastic cancer nurses. So again, please feel free to stay online and to carry on with this discussion. We will be hosting another one of these webinars later in the year, which is specifically aimed at healthcare professionals. And we will be providing more information about this in the coming months. We are going to circulate an exit survey, an evaluation of the webinar today. We would be most grateful if people could please complete that survey. Let us know what you thought of the webinar tonight and any improvements that you might have or any improvements you would like to suggest in order to make this more useful. So finally, it really just remains for me to thank Dr. Jenny Wheel, to thank Clem Bayard and Dr. Deborah Lawson for their time today, and particularly to acknowledge and thank Sally Ann Ryan, Nicola Morgan, Rebecca Peart, Anika Smithson, Carol Arbuckle and Robin Tucker from the Cancer Council, Victoria's Cancer Information and Support Services, and Sonia Brockington from the McCabe Centre for Law and Cancer for all their time and effort to put this webinar together tonight. So for those who are staying on to chat, you'll see in the top right-hand corner that as soon as I get to it, there will be a chat function that comes, a Q&A function that comes up. So just bear with me as I activate that. So now in the top right-hand corner of the platform, a Q&A icon has been enabled. So you'll need to click on that icon in order to ask a question and to see any answers. So for now, we're going to close off the audio, and for those who are staying online, we'll see you online shortly. And thank you all very much for your participation, for joining our webinar, and we look forward to presenting more of these webinars to you in the future. Thanks very much.